I'm an interventional cardiologist, and I thought I'd just start off by explaining what that is, because a lot of people get confused about what interventional cardiology is. They wonder, well, are you a surgeon? Are you not a surgeon? So basically, this is kind of a subspecialty field in cardiology. What it focuses on is minimally invasive procedures for the heart as well as the vasculature in the body. It involves placing small tubes within your wrist, within your neck, or within your leg, feeding these small tubes into your heart and delivering specific types of therapies, whether it be balloons, stents, or now heart valves can be delivered also. It's completely separate from cardiothoracic surgery, which involves open heart surgery, stopping the heart, and being able to fix the heart manually with your hands. So as Dr. Gore had mentioned, atherosclerosis, this is a disease of plaque buildup in the arterial walls. It's usually plaques of fat, cholesterol, and other substances. It can clog not only the arteries inside your heart, but it's a systemic disease and can clog arteries anywhere in your body. And this is kind of how it looks here. So this is how a normal artery looks here when we're all born. As we all get older, plaque builds up in the artery, and what happens when plaque builds up in the artery, looking at this cross-section, it narrows the flow within that artery. Well, eventually it gets really narrow. As you can see, the small donut hole, this is what's left of this artery, and this is all plaque that builds up in the arteries and restricts blood flows. And as I'll show you on subsequent slides, these plaques can rupture, blood clots can form and block off arteries. These plaques, as I mentioned, are filled with cholesterol and other types of inflammatory cells, and that's why it's important to follow the diets that were outlined and to exercise. So let's start off by briefly going over what a heart attack is. A heart attack is a blockage of the vessel that supplies the major muscle inside the heart, and there's different arteries, 3 major ones usually, and a bunch of branches also. And so what happens in a heart attack is plaque builds up in the arteries, as mentioned, and one of those plaques eventually ruptures as it becomes thicker with dense inflammation and cholesterol. Well, when that ruptures, what the body does is it says, oh, there's something foreign here. Let me try to block this off. And so a small blood clot is going to form with some of the blood factors that are in the vessel, and that's great. So it's walled it off. But that process continues to form. That blood clot continues to grow, and eventually it gets so big that it completely blocks off flow to that area of the heart, and that's when someone is having a heart attack. So what can we do for heart attacks? What we do in interventional cardiology is we take patients urgently to the cardiac catheterization laboratory, which is pictured here in your upper left-hand corner. And what we can do is we can put a catheter through either your wrist or your arm. We feed it up into your heart. We inject dye to the blood flow supplying the heart, looking to see where the blockage is. And this is a kind of a simulation of how that looks, where you can see the blockage. Once again, this is an artery that's lying on the outside of the heart, supplying the heart muscle. So once we find the blockage, we are able to put a specialized wire through the blockage, put a balloon over that wire, push the plaque up against the wall, and in most cases put a stent in to keep the vessel open. And that restores the blood flow. And obviously time is crucial, so we're all doing this relatively rapidly. Now stents, as Dr. Kumar has mentioned, have come a long ways away from the 90s and from balloon angioplasty in the 70s. What we started out with was very thick pieces of metal, basically rigid tubes, as you see here in your upper left. As technology evolved, we were able to narrow the thickness of the stent sizes. We were able to have stents that are much more pliable and much more able to get to tortuous vessels or in areas of calcification. And now, actually, in 2016, we actually have stents that are made of a polylactic acid, or basically a polymer that can dissolve and within 3 years no longer be present in the artery. And finally, for patients that have a lot of blockages or blockages that can't be fixed with stents, there is the traditional open heart surgery, which is used a lot less these days compared to previously because of the advancing therapies that we've seen with stents and catheters and the specialized equipment that we have. And basically how I explain this is, as an interventional cardiologist, what I do is I fix the road with a stent. What a CT surgeon does is they build a bridge over that broken road, and that's what bypass surgery does. As mentioned, for patients that need it, this is a life-saving therapy, but as technology has advanced in the past 10 to 15 years, bypass surgeries are required less and less. switching gears a little bit about transcatheter aortic valve replacement. So this is a newer technology that was approved in 2001. It's a minimally invasive procedure in which we can replace the aortic valve in patients who have something called severe aortic stenosis and are moderate to high-risk candidates for traditional open heart surgery to replace the heart valve. Currently in the U.S., we have 2 transcatheter valves that are FDA approved and many more in the pipeline that have already been approved in Europe. So on your left-hand side is what a transcatheter aortic valve replacement surgery is, in which we create a small incision in the leg, feed it into the heart with a catheter where the valve is mounted onto the catheter, and we deploy it in the heart, and I'll go into a little more detail about that. Whereas traditional open heart surgery actually requires, open up the chest wall, putting the patient on the heart-lung machine, and taking out the old valve and putting in the new one. So these are the 2 currently FDA-approved valves here in the U.S. To the left, here is a Medtronic valve, which is a self-expanding valve. To the right, this is a balloon expandable valve, which is made by Edwards. As you can see, the profiles are slightly different. The Medtronic valve is just a longer, more slender tube profile, and it sits above where the native valve, or the valve you were born with, sits. This valve sits a little bit lower, and depending on the patient characteristics, those would be the deciding factors as to which valve we feel would be appropriate for the patient. So what is aortic stenosis? It's a narrowing of the major heart valve, that is the aortic valve, which allows blood flow to leave the ventricle to the rest of the body. As we age, cholesterol can build up onto that heart valve. It becomes thickened, it becomes difficult to move, and it basically stenosis and goes from being about the size of a dime to a size of a pinhole. Patients usually develop symptoms as it narrows, which can include shortness of breath, chest discomfort, fatigue, lightheadedness, and even passing out. So looking here at your upper left, a normal aortic valve is a trileaflet valve, or has three parts to it, kind of similar to a Mercedes sign is what I think of, or a peace sign. And it opens and closes normally in our earlier days. As we get older, what happens is calcium deposits develop, and these can also be plaques that develop here in the valve. And what happens is it restricts the opening and closing of the heart valve. And so these are the 2 transcatheter valves that we have here. To the left here is a balloon expandable valve, which we put across the old valve. We put this balloon up, and we're able to push the old valve over to the side. We don't take the old valve out, we just push it to the side, and we actually need that calcium to be able to keep these transcatheter valves in place. To the right is a self-expanding valve, which once again is going to go through the leg, up into the heart, across the old valve. We deploy it, and sometimes we may actually push it to the side a little bit more with a balloon, pushing away the old valve. So transcatheter mitral valve repair is a new and exciting therapy for patients with something called mitral regurgitation, which, unlike aortic stenosis, which is a narrowed heart valve, this is a heart valve that leaks too much backwards. So the mitral valve is a valve that also sits on the left side of the heart, and what happens with mitral regurgitation is the valve has some sort of deformity to it, or has some sort of buildup of calcium which prohibits it from opening and closing regularly, and in this case blood flows backwards into the left atrium and lungs rather than forward out into the rest of the body. So most patients would require open heart surgery to fix this problem, but in 2013 we had an approval of something called a mitral clip, which is basically a clip procedure which allows us to clip certain parts of the leaflets together, so that way the valve does not leak as much. Now once again, this is just currently approved for high-risk patients, or patients that are not good surgical candidates. It is based on a surgical technique which was pioneered by a CT surgeon named Octavio Alfieri, based on something called the Alfieri stitch. And so basically what Dr. Alfieri did is he invented a procedure in which he can bring together certain parts of the mitral valve to take it from one orifice to 2 small orifices, as you see here on the left side. Well, one of the interventional cardiologists thought, well, gee, can I do that with a therapy that's delivered through a catheter. And what they eventually came up with is something called a mitral clip, which is, as you can see, maybe half the size of a dime. What the mitral clip does is it goes into the area of the mitral valve, which is seen here how a normal mitral valve functions. It has certain chordae that kind of tether it to the heart walls. And when it closes normally, blood flow can go out through the aortic valve to the rest of the body. Well, when it's not closing normally, what happens is some of the leaflets can get pulled out to the side because there's been changes in the ventricle, or because these chordae have gotten stiff, and what happens is blood flow can go backwards rather than forward. What mitral clip does is it comes across here to the valve, it clips certain aspects of the abnormal valve leaflets, can bring them together and decrease the amount of regurgitation that goes backwards rather than forward, improving the patient's symptoms and quality of life. And this is once again another picture here of the mitral clip. What it is you've got a gripper here and you have part of the leaflet holder. The leaflet goes into these two areas. They clip them together, bring the valve closer together, and create two orifices to try to stop the leakage. And this right here is just a picture of the actual catheter that goes in. This is another procedure which, once again, we can do it on a beating heart. We don't stop the heart. We go in through the leg. We go across over from the right side to the left side of the heart and are able to deploy the clip and decrease the amount of mitral regurgitation. Thank you.